We do have an afternoon panel discussion to come. We are going to hear from the players' perspective in just a little while, but next we are going to be rejoined by Dr. Anthony Kontos, who's talking about the emergent findings in concussion and separating fact from fiction.
All right, show of hands again, just so I have context. How many people were not here this morning? Just you, two of you. Okay. Well, welcome. And some of this, originally we were I kind of thought we had two totally different audiences. So the good news is I was up really late last night to change these slides and integrate some new stuff. So you're not going to hear an awful lot of similarity to what I said earlier, although I think there will be some thematics that cross across all of the presentations. And one thing I will do is, you remember what I was talking about with regard to the removal from play? So one of the things in my mad, research scientist brain, I stayed up an extra hour last night to do some reanalysis of some data that we've recently submitted for presentation. So they're very, very much not yet peer reviewed. And that slide won't be on your handout when you get them at some point or online. But I want to share the information because I think it's even more compelling about the importance of that, and it'll kind of expand on what I said this morning. So again, the research that as I mentioned earlier today, a lot of support there. I won't go into a lot of detail here. These sound an awful lot similar to what I said this morning, but again, I'm going to expand them and focus on some different areas. So for those of you, the two of you that are new, this will be totally new, but for the rest of you, it should be at least somewhat new for you, right? Okay, so, and here's Mickey giving the Concussion 101, or Michael again, as we're going with here in Ireland, giving the Concussion 101 talk. And a couple things to bear in mind. We heard a little bit from Kevin and others about, mechanisms. Mickey talked about the metabolic pathways and things like this. And I think when we talk about this, it's one thing, and to look at a brain image and see what it might look like and how it looks in static is one thing. This is another one of those types of images, which shows basically a focal frontal impact with a coup contre coup to the occipital lobe. And we see this in what we would call a linear impact. But let's be honest, linear impacts are a bit of a rarity in sport. Most of what we see has at least some component of a rotational impact. So it's rare that we see what will show up on this next video here. So if you could play this video, that'd be great. I hope there's no audio. It's pretty awful. This is the world's worst youth American football drill. Could you play it one more time? This head first, this isn't what happens anymore. This is about 5 years old, though. So put that into your frame. 5 years ago, this kind of drill was being videotaped and put onto YouTube. You can actually search and still find this out on YouTube. And you hear all kinds of awful sounds from this kid afterwards. That's a pretty straight-on impact. You don't see that a lot in sport. Even in football, we don't see a lot of that helmet-first stuff anymore. I mean, we've really worked it out. Coach Tomlin for the Steelers, his mantra was, don't hit with the head, don't lead with the head. And this has really kind of resonated now with football. Of course, with those little kids, you notice the size proportion. You talked about the head. It's like Charlie Brown. I remember when my son was two years old, and he could barely hold his head sideways. It would just kind of fall over. He looked like a little Charlie Brown blown up. These helmets, oftentimes the kids don't really control them as well as you think. So in a non-helmeted sport, that's one advantage, is you don't have that weight on the head, which the neck just isn't really ready to bear at this point. So that's a linear impact. And frankly, a linear impact, we could argue, has kind of a focal energy point and an exit point, and you could maybe even think in terms of pinpointing symptoms and impairment from that, although it's not quite that simple. A rotational impact, in contrast, is going to be much more diffused. It's going to involve a lot more in the way of axonal tearing and all kinds of different things, microbleeds potentially, and things that may or may not show up on scanning, but certainly would show up in a functional assessment. And that one is more evidenced here, and we keep going back to ice hockey. They're going to probably think we don't like ice hockey here, but it's actually really good because it's a dynamic environment where we see energies coming from a variety of directions. So if you play this video.
Save, 134 for him. Domi bombing, we go to OT. In the overtime, look at that.
He rotated
hit.
Almost 180 degrees.
Tucker just laying out Sammy Kapanen. And I know this looks kind of funny when you look at it. Kapanen having all kinds of problems.
Gross motor impairment.
Man, you think about what's going on there. That's scrambled eggs right there, Billy.
It's one of the best announcer comments ever for
Kapanen did
concussion.
eventually make it back to the bench.
So it's scrambled eggs, and as much as it makes light of the situation, it really is a good analogy here. As Mickey talked about the egg inside the brain or inside the cranium. And the reality here is immediate impairment. No one's going to question whether this is a concussion. That athlete was out a subsequent month, and one of the reasons is he presented with not only that impairment, but tremendous dizziness at the time of injury. And we'll talk a little bit about the role of dizziness. But rotational impacts, certainly a totally different animal than what we see with those linear impacts. So what happens when this occurs? Mickey went through some of these symptoms, but he didn't talk about them in a way that we've learned from looking at massive amounts of data. So the metadata world that we live in now, we looked at over 1,400 concussions. And when we looked at the symptoms in 1,400 concussions, what we found in the first week, so this is in that early subacute, post-acute period, what we find is that basically every athlete has a large constellation of global symptoms. They don't present as clearly early on with like maybe emotional symptoms or cognitive symptoms. That tends to manifest a little bit down the road. That's not to say the ocular and the vestibular and some of the things you heard earlier aren't evident then and you can initiate treatments early. But as a symptom piece, just that piece, it's very global. Only a handful of these kids have, and this is using a certain type of factor analysis approach to look at these data. And what we did is we basically parsed out, some people have sleep, some people have affective, and certainly there are some people that are much more severe that may have vomiting and numbness and some of these more neurological deficits. But this is in a first week, and this is what it looks like after the first week. It starts to parse out, and we start to then move towards those clinical pathways or trajectories Mickey talked about earlier today. So we see this mood, anxiety, cognitive, migraine, and sleep patterns. And you got to think of these as potentially, again, overlapping. A lot of people like to think of sleep as this ubiquitous thing that gets affected with concussion. It's certainly concurrent and very common, but it doesn't occur unanimous across all injuries. So although sleep is certainly important, if you're not sleeping, it's hard to recover. It's definitely not present in every single case of concussion. Again, we have to look at each individual, and we have to realize that these are evolving patterns. So if you early on look at somebody, they may look one way, and then if you look at them a week or two later. So by a show of hands, how many of you are seeing people in the first week following concussion? Those of you that are working with concussion. How many of you don't see them in the first week? You see them 2 weeks, 3 weeks, etc. So just one. Oh, we just heard about the lack of neurology here, right? So Nave and others have certainly see this kind of maybe more of this constellation here. Those of you that raised your hands earlier, you're probably going to see that more global presentation, which if they have a high score on that, they usually don't do so well in the recovery phase. So, not to beat a dead horse here, but in all fairness, they're all different. And we have to look at that patient-centered care approach to really get a grasp on this. Even if we use our clinical profiles, we still have to treat each patient individually because there are nuances, risk factors, and combinations of things that will drive that. So with that in mind, we developed this, which you've heard a lot about today. But what influences this? Why do some people go here, 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 and here? Earlier, we heard some allusion to certain risk factors. I'm going to talk a little bit more about those right now. And, I had an advisor back when I was doing my doctorate who said, if you ever have a slide this busy, don't show it in public because it's too confusing. So let's just forget about some of over here and focus on here and here right now. And what I want to draw your attention to is those far left boxes. These are the sort of constitutional risk factors that you bring to the table. So the pre-morbid stuff before you actually get hit or have an injury. And these types of factors will drive whether or not you're going to have ocular, whether or not you're going to have vestibular, or maybe cognitive if you talk about LD and ADHD with the attentional issues. We certainly know age and concussion history and other things play a role. But really importantly, let me go back. This didn't do the animation I was hoping for. In the middle, you see dizziness and post-traumatic migraine. And I'll come back to those because things that happen immediately following the injury may play as much a role as those things that you bring to the table and driving where you're going to head with the injury. And another thing, you heard that this kind of plays dirty concussion. Another way to think of it is it magnifies pre-existing conditions. So if you have an anxiety issue, likely concussion is going to blow that up. If you have a vestibular motion sickness issue, likely that's going to be the issue. I'm going to give you a painfully personal case, not myself, but my wife. This past year had her first concussion, at least diagnosed, so maybe she's had 27 other ones based on her earlier slide. But I doubt it because she wasn't in sports that would have had those kinds of risks. But so she had a concussion. She was standing next to my son's soccer or football practice. A girl was taking PKs, practicing. She totally errantly missed the goal and just crushed my wife in the side of the head, unsuspecting, massive rotational impact. All of that sets her up like a bowling pin for trouble, but let's add some fun stuff into it. She has a migraine history, and pretty severe migraines sometimes. She also gets very car sick. So she has a motion sickness component, a vestibular component. And when she came back, she was, tears in her eyes. I'm not trying to embarrass my wife, but it was a brutal hit. I saw it from afar, and it didn't look good. And she's really upset, and I can tell right away that she's symptomatic, and this is problematic. So where did we proceeded to get into the car, and then drive back to the house, and not 2 blocks into it, now she's got ocular disrupt. The driving and the scrolling environment, and I know Anne's probably chuckling because she was, Anne was one of the treating clinicians. My wife said it was okay to talk about this, so that's all right. But the reality of what I'm getting at here is that she brought a whole bunch of stuff with her. And then on top of that, she showed up with, right after the injury, she has migraine-like symptoms, post-traumatic migraine, dizziness, and ocular problems. So all of those things are adding up to trouble for my wife. It took her about a month to recover. The good news is because of that post-traumatic migraine, after a couple days off, a couple days rest, she was immediately put into activity, and that had a tremendous effect on mood, a tremendous effect on that feeling you heard from the patient of, there's something I can do, there's something that we can do to get this better, and it went a long way in getting her better. I don't have a case control to compare her to, but I imagine she got better a lot quicker than had she just been resting. So, with all of that as a backdrop, there are a lot of things that set us up for trouble. We've already heard that the average, especially when we look at youth, is going to take about 20 days. We're finding more and more, even at the college age. We're doing a study right now of 30,000 collegiate student athletes at 30 institutions. And what we're finding is they're taking, on average, about 13 days to recover. What was the previous? Anyone want to guess what the previous average was for recovery? We heard earlier, it's about a week. Why was that? Because football was on Saturday. It was about a week after the injury. It wasn't a coincidence that was happening. So again, the recovery time is much longer. It depends on the domain. Some things like vestibular, it may take longer to recover. Other things, may recover faster. And we need to find out who are these people. And so one of the things we're looking at is not only what happens at the beginning or what you bring to the table, but these things, the immediate response to the injury. It may be reflective of underlying metabolic disruption or even structural changes that we're not yet able to measure. But the reality is when these things occur, we see worse outcomes. So a good example here, we published this in the American Journal of Sports Medicine, if you're interested in it, is we wanted to know, and this has been a big point earlier today, is on-field. So if you're the first person out there, if you're the physio or the doc and you're saying, well, what's going on here? One of the first things I'd be looking for is dizziness. Okay, and the reason is because of this slide. Dizziness was associated with a 6 1/3 time greater risk for a protracted recovery. And interestingly, and this is maybe, I'm a researcher, this is super interesting to me. Look at vomiting and LOC. Does anyone who knows anything about statistics notice? It's not significant here, but notice what's going on with those two? They're actually what we call protective factors. Now, in the univariate analysis, before we loaded all of the variables, they were significant. As soon as we added dizziness in, they fell out. But I pose the question to you, why might loss of consciousness and vomiting be protective factors for a longer recovery from concussion? I see several of you muttering silently to yourself, but we can say it out loud. Does anyone want to take a guess? What's that? They pay attention? Yeah, so when you see somebody, when you see somebody throwing up like this quarterback at the University of Arizona, and it's on the Jumbotron and everybody saw it, that athlete's going to get managed very conservatively. Everyone's like, aha, concussion. Which is the other one? Loss of consciousness. If they're knocked out, even if it's brief, it's obvious. They're not moving. You know they're concussed, or at least you're suspecting concussion. There certainly can be other brain, cervical, and other injuries that could cause this as well. Also, though, we must think of loss of consciousness as sort of a pseudo-protective mechanism. The brain is shutting down. It's literally like detaching, it's taking itself off the hook, so to speak, from any demands from an energy perspective. And there's been some argument in the literature with animals that may represent like a baby coma, almost like a shutdown mechanism so that the resources are spared to help recovery process initiate. So there is some, although there's no human evidence of this, there's certainly some logic to that argument as well. So the next sort of problematic post-injury thing we want to look at is post-traumatic migraine. Not migraine ahead of time, but rather migraine after the fact. So you've been injured and you start to have symptoms, and I think Kevin mentioned the lights. I'm looking at this light here, and that light bothers me, so I imagine that athlete, might have been caught in the lights. Lights can be pretty bright and bothersome, but really lights that are even mild, like these overhead lights here, would be really problematic for someone with photophobia. And phonophobia, the sounds of the stadium, everything gets magnified, in addition to having nausea as well as the headache. And again, that's a general definition. It's not a clinical, but it's a good one to start with. And when we look at athletes that have this, and again, this is also in high school, we find a similar effect. When we compare them to groups that don't have any kind of headache or those symptoms of migraine, they're about 7 1/3 times more likely to have a long recovery. However, it's more than just headache. When we look at a headache group, which is really hard to find just headache without any of those symptoms of migraine, so we looked at a really big database. But once we did that, we realized that it's not just headache, it's the migraine type headache. And some have argued like cluster headaches and other types of headaches may also play a role here, but we certainly don't measure those as well. So here's what happens to your cognitive performance. It drops dramatically for them, and it stays dropped. So it doesn't just occur transiently. We see a prolonged recovery as well as a greater initial impairment, all of which beg not to return those athletes and to monitor them very closely. So again, it's more than just the headache. There we go. Okay, so earlier today, and I'm not going to try to bore you too much with the details from this morning, but we talked about what happens if you continue to play. And we said that that's generally a bad thing. Does anyone remember the amount of time it would take if you stay on the pitch? Yeah, 44 days versus 22. And that's really doubling the recovery time. And that's, again, that resonates with people. But there's a lot more to that story, as I found out last night and looking at the data a little more closely from our poster that we're presenting, or our presentation that's going to be this spring. So again, hide it, minimize it. That's kind of the mentality of athletes, myself included back in the day. My wife always laughs when I try to refer to myself as an athlete at this point, but you guys get the idea. So again, that was the same study, about 70 athletes. And what we found, as I've showed you this morning, we saw that the people that stayed in are in trouble with memory. They're in trouble with their reaction time. They report more symptoms, and they are more likely to have a long recovery. Now, that's part of the picture. So this was what I showed you today. It's better to sit out for a couple weeks than 4 weeks, 5 weeks, etc. But, Coach, I only played a couple of minutes. Does it really matter? Okay. Yes, it does. So if you're removed immediately, 19, again, this is a subsample, so the numbers are a little different. If you play only 3 to 15 minutes, so I think we could all argue that's a brief amount of time post-injury to continue exerting and or being exposed to potential hits. We don't know what the factor that's causing these findings is. It could be either or. And then we look at those that stay out 15 minutes. Now, we got to be really careful because what we don't want to do is say, well, that's only 29 days. That's not that long. Maybe it's worth it. That's what an athlete, a coach may think. But I don't think of it that way. I think of it's an increasing dose response here. The longer you stay in, the longer you exert, the longer you expose yourself, the worse off your outcome is. And so you have to get out as soon as possible, not delay, not think about it. The moment there's a suspicion, as we heard earlier, that's the time that you have to initiate this. That's the time you have to get out. So again, it's a resounding yes, and we extend the findings from this morning to say it not only is about getting out, it's about getting out as quickly as you can, so immediately. And interestingly, in that study I referred to with 30,000, we're finding similar findings, although this is college age, so we have to temper that. They tend to recover a little faster. So they took 10 days if they were removed immediately, 15 days if they stayed on the field. That population is probably more in line with your senior players here in the GAA, because I think they're about like college age on average up to it sounds like early 30s, because they're not continuing to get paid, so they kind of end sport around the mid 30s, I would say, at the end point. So again, we see a similar finding here in a really large database with college age. So what I showed you earlier was high school. And then the last thing I want to point out today before I wrap up and take some questions if there are any, is this notion of delayed symptom reporting that I alluded to in the panel discussion earlier. One of the things that none of the data I just showed you deal with is the fact that some people continue to play without knowing they have a concussion or without anyone else knowing they have a concussion because their symptoms are delayed. And what we found so far in our database, and these are preliminary data for this particular study, is that 30% of athletes, and it's actually a little higher now that we've reanalyzed it with almost 1,500 concussions, 30% of them do not present with symptoms until about 6 to 7 hours later on average. So we're on the bus, we're on the plane, we're on the way home, we're back in the locker room, what have you, or it's not even until the next day. And that's where I want to urge all of you to not only assess this injury that might have occurred when you're suspicious at the time of injury, but then later after the game in the same athlete, particularly if they carry those risk factors I mentioned earlier, migraine history, they had dizziness, any of these sorts of things. And then again, you want to follow up again the next day because you just never know when the presentation will fully blow. Females stayed out there about 50 minutes on average in this study. Males were out there for basically an entire practice, or in the case of like a soccer game, the whole 90 minutes. And so this is problematic. So they're playing at least another practice or training session or a whole half or whatever. And that's really problematic in the effects based on what we saw on that earlier slide. If they're staying out that long, we're talking 40 days recovery. So it's very problematic. So maybe what we need to do is say it's better to get out now instead of playing a few extra minutes to win the championship or whatever. And I know that's a hard sell when you're in the throes of the game. But do we really want to risk catastrophic injury, as we've heard in the headlines in recent times here in at least I think it was in England with the rugby kid. But this is problematic, and we want to make sure we nip that in the bud. But we also want to minimize the recovery time and make sure kids are getting better, faster, particularly kids, not just the professional or elite level amateurs that you have here in the GAA. So with that in mind, the conclusions are up there for you to read. I think you want to be aware not only of the premorbid stuff, but also what happens at the acute time on field and in the first week following injury. Are they migrainous? Are they dizzy right at the time of injury? What type of injury? Was it a rotational? Was it a linear? And then finally, when we remove these athletes, get them out as quickly as possible because there's a growing sort of effect, a dose response, if you will, over time, the more time that they are on the pitch or on the field. And thank you again. And it's been a pleasure this whole week talking in the hallways, everything. And we look forward to, I think, the panel this afternoon, any questions you may have. Thank you.
If there are any questions, I'll certainly take those.
In the 30% of people that you say get delayed symptoms, how do we identify those at the time of injury?
I'm sorry, how do we identify them at the time of injury? Yeah. Well, so, it's a hodgepodge of different athletes. Some of them truly did not have symptoms, and there was no major mechanism where everyone said, oh, we need to look at this, it might be a concussion. These are what we would call under-the-radar hits or collisions or things that are off the ball maybe and they're missed, they're not on TV, whatever. And again, this is Division I collegiate athletes, which in many regards is kind of like a minor league professional really in the States. And so, for them to have been missed is usually pretty rare. Although in some sports, maybe field hockey and soccer, they have a little less coverage, a little less TV coverage as well. But some of them don't present or don't say anything about their symptoms, probably. Some of them might be missed, just nobody saw the hit. Some of them may truly not have any symptoms until the following day. We don't know the answer to that because we can't really assess that. It's a great question. It's probably a combination of all three groups.
Can I ask you a second thing?
Sure.
I think it would be really interesting if there was some way of actually assessing players who were subsequently found to have concussion, how they performed on the field of play when they had been concussed. Because if there was evidence to show that they didn't perform very well, that would be a big tool in stopping them staying on the field.
Right. And in the past, like let's say 5 years ago, a good example was, how many saw the World Cup? Germany, Kramer, the defender, he got crushed in the corner. It was, he was clearly out for a brief moment or two, but yet continued to play. The evaluation was like, all right, you're good to go. And he continued, well, why? Because it was the World Cup final. He has no recollection of that day, that game, anything. His performance on the field, on the pitch during the next 15 minutes was so abysmal. Luckily, nobody was coming up that right wing or they would have scored. Because he literally was just aimlessly wandering about the pitch. And that's sometimes where you might, behaviorally see that. But we don't have any data on that. That is the most compelling story and probably something that personally I would love to do, is to be able to look at video or look at performance and say, these folks that presented later, did they really not do well in the game, or did they look just normal and it's almost impossible to find them? We don't know the answer. It's a good question. Any other questions? Okay. Oh, I was off the hook. No, go ahead. Go ahead.
Just on post-concussion syndrome, so things that would go on for months after an incident, an opinion on that I'd really appreciate.
I'm sorry, what was the question?
So post-concussion syndrome, so some of the symptoms just don't go away.
Yeah, that's
and not necessarily within the time limit that you would have discussed even on the screens there.
Yeah, that's correct. And you bring up the issue of these lingering symptoms, and there's certainly some cases, as Mickey and Ann and others will attest to in this room, that aren't getting better. And maybe they don't even have a long history of concussion, but they had this one impact and suddenly they have tremendous symptoms that at least from the evaluation appear to be related to that injury as opposed to like comorbid psych or other things going on. And it's always important to extricate, that piece of the puzzle, that it's not mood, that it's not something else going on in their life, substance abuse, all these different things that could be going on. What we know about post-concussion symptoms is that a large number of individuals who develop that are probably mismanaged early, are probably not given the appropriate treatments early on, and it drives them down that pathway. There's another minority of patients who are probably struggling more with being out of sport, being away from teammates, maybe not getting back to performance, maybe having ancillary issues, being held out of school if that was what was told to them. So there's a lot of things that can be going on to drive that. One of the things I earlier today talked about how many, there's like 600,000 of these cases that aren't really getting treatment. And I think that's the most critical piece of post-concussion symptoms or syndrome is if we get earlier treatment, might we mitigate that and really minimize it to where it's only a handful of individuals that have a real select set of risk factors? Or will it always be there? Don't know the answer, but I'm hoping that we can learn the answer to those questions as we move forward. It's a great question. Thank you. I think we're all set. We're time here. Thank you.